My name is Lauren Foley, and today I'll be talking to you about Capgras syndrome. This disorder was named after Joseph Capgras, who first defined the disorder in 1923, calling it illusion de Sosie. It was originally thought to only afflict women, demonstrating a connection to hysteria. It is now known to be primarily caused by brain degeneration. Capgras syndrome is a type of delusional disorder, which, according to the textbook, is a condition in which a person has a non-bizarre delusion, no other psychotic symptoms, and few changes in overall functioning other than the behaviors immediately surrounding the delusion. This condition is too rare to have a DSM entry, but fits the persecutory or unspecified delusion type of a delusional disorder. According to the DSM, the criteria for this disorder is as follows: the presence of at least one delusion with a duration of at least 1 month. Not meeting criterion A for schizophrenia, which is the presence of delusions, hallucinations, disorganized speech, and grossly disorganized or catatonic behavior. The absence of markedly impaired function and obviously bizarre behavior. Delusional periods that have lasted longer than any manic or depressive episodes, if any have occurred, and the behavior being unattributable to the physiological effects of a substance or the symptoms of another disorder. Capgras syndrome is the most prevalent delusional misidentification syndrome. It is characterized by the belief that an identical duplicate has replaced someone significant to the patient. This duplicate can also replace an inanimate object or animal. The patient may be agitated and aggressive towards this person due to a defect in recognizing familiar faces. This disorder appears in both psychiatric and non-psychiatric cases, such as patients with brain damage, including Alzheimer's disease, dementia, Lewy body dementia, epilepsy, cerebrovascular accidents, pituitary tumors, and advanced Parkinson's disease. The most common treatment for this disorder is a combination of therapy and antipsychotic medication. However, because this is such a rare disorder, there is a lack of empirical data that makes it hard to treat patients effectively. The goals of therapy for a patient with Capgras syndrome involve establishing a therapeutic alliance while negotiating mutually acceptable symptomatic treatment goals, expressing empathy and interest in the patient's predicament, and avoiding confrontation of the Capgras symptoms. However, if the patient is engaging in self-harm or violence, hospitalization is necessary. Another important part of treatment is treating any comorbid disorders the patient may have. Common comorbidities for this disorder include vascular diseases such as atherosclerosis, hypertensive encephalopathy, and subarachnoid hemorrhage. Neurodegenerative disorders such as Alzheimer's disease, advanced Parkinson's disease, and dementia. Other CNS impairments such as epilepsy and fat embolisms. Infectious diseases such as HIV and AIDS, acute viral encephalitis, and malaria. Metabolic disorders such as hypercalcemia and hypoglycemia, and toxins such as mercury, manganese, and arsenic. Capgras syndrome is caused by brain damage in the bifrontal, right limbic, and temporal regions of the brain, which leads to aberrant memory functions, self-monitoring, and reality perception. These neurological deficits cause an inability to integrate emotional information processing and facial recognition. This disorder can have many terrible effects on patients and their families, including intrapersonal and interpersonal conflicts, poor social relationships, self-harm and violence, stress on caregivers, stress caused by social stigmas, and socioeconomic conflicts caused by the patient's inability to hold a job. According to studies by Kuzem, Edelstein, Oibod, and Barrett, this disorder presents in 1.3 to 4.1 of patients in all psychiatric conditions, and in 3% of patients hospitalized for psychosis. According to a study by Silva, Leon, Weinstock, Sharma, and Klein, it presents in 50% of patients with schizophreniform, 34.8% of patients with brief psychosis, and 23.9% of patients with unspecified psychosis. Thank you so much for listening to my presentation.